Thank you for staying with us. Nigeria is one of the countries with the highest maternal mortality rates in the world, according to the World Health Organization. The maternal mortality rate of Nigeria, 814 deaths per 100,000 live births. The lifetime risk of a Nigerian woman dying in pregnancy, childbirth, postpartum is 1 in 22. A great departure from the lifetime risk in developed countries, which is put at 1 in 4,900. How can the country achieve a turnaround in this situation? Joining me via Skype from the United Kingdom is the second Vice Chairman, Association of Public Health Physicians of Nigeria, Lagos Chapter, Alero and Roberts. Good morning, and thank you for joining us, Dr. Roberts.
Thank you. Thank you very much for having me, and good morning.
Good morning. Now, when you look at the statistics, that is 814 deaths per 100,000 live births, and you place it side by side efforts made by the government over the years, one wonders what we are not doing right, such that we are not seeing that significant change towards all of the efforts we have made over the years.
Well, that's a very interesting question, and one that I must tell you has plagued us for many, many years. The truth of the matter is, what we're seeing today is the culmination of decades of underfunding of both the education and the health systems. So, for example, if I'm to bring it down to the ground, the Association of Public Health Physicians, as you know, public health physicians were involved in the public health of the community as such, and therefore, we maintain very close relationships with the community-based organizations, NGOs, and foundations that deal in different areas. And for maternal and child health, we are very pleased to be able to partner with the foundation, the Wellbeing Foundation, data and insight into what some of the causes at the grassroots could be. And what I have found is that a lot of it boils down to poor education. The women simply do not know what the danger signs are in pregnancy and early infancy as regards what to do, where to go, what are the danger signs, when should you go to a health facility, which health facility should you go to. And now, of course, with the pandemic, things have gotten even worse. But we have found over the years of collaborating with community-based organizations and foundations such as the Wellbeing Foundation, that there's a lot we can do at the grassroots to redress some of these issues. So I have been able to participate in a lot of their pilot schemes and see which ones can be taken to scale to make a difference to the country overall.
Now, you talked about a lot of challenges. Besides or aside the fact that most of the women do not know the danger signs, what more do you see tradition and religion coming to play?
Of course, tradition and religion come into place. I mean, we are a function of where we were born, what we've been exposed to, what our cultural norms and value systems are in the area. I mean, basically, I'm sure that even right now, what you do or do not do has been very much affected by what your mom told you first, then your parents, then your school teachers, etc., like that. So you can imagine that any woman who's growing up in a situation where this is what she's told, this becomes the most important thing that she's going to do. Where she goes when she needs healthcare, who she turns to. All these things have an important and huge factor to play. So when culture and religion are not tempered with the proper education, that's when we have a problem. So we can actually build all these things in, and when you think about it, you will find out that a lot of what you've learned over time has been factored by three things: culture, religion, and education. If you remove one, you only have the remaining two.
Now, are we looking to perhaps look at community communicators who are seen as figures that they can trust to help in the aspect of educating these women to push the message forward?
Absolutely, yes. We do, and the Wellbeing Foundation uses a lot of them, and we are learning huge lessons from that. So, for instance, they've got an initiative where during the pandemic, women were afraid to go to the clinics, to the health facilities, but we had what you would call community communicators, but who in fact are the most trusted hands in any communication, in any community. And those are the midwives, the hands that actually bring each and every one of us into the world. So we had our midwives, they still go out, they still communicate with the women, and now they're using all sorts of things, WhatsApp, they've created WhatsApp groups with the women where they can exchange information, the mothers can ask questions and get credible, reliable information. This is something that we want to take to scale nationally, where we can empower midwives as community communicators for everything, not just maternal and child health. You can do it for water and sanitation. You can do it for personal sex hygiene education in adolescents, women empowerment, setting up of micro, small and medium enterprises. It can be done in any area of human endeavor. But the midwives have proven themselves to be people that the community trusts. And once we empower them and once we can roll them out, Nigeria did it at a time. We had the midwife service scheme. But, you know, without the proper political commitment, these things start and fail. But what the WBFA has been able to do is show that this thing can grow organically from the grassroots, tailored to each peculiarity of every single different community. So you don't have a one-size-fits-all. But you do have a situation where what you call the community communicators can be harnessed and empowered and leveraged on to take the right message out to the people and get those local voices from the grassroots and bring them even to the global dialogue table. These are things that have worked elsewhere. These are things that have worked over time. They're working in small pilot schemes. And what we need is to now do a national scale-up.
And if I may go back to something you mentioned, you talked about certain persons, that is midwives. Are you talking about the traditional birth attendants, whom a lot of these women turn their attention to and have stood in the gap between these people not being able to access quality healthcare at the grassroots? I wonder if these are the persons you are talking about, because that has also generated a lot of concerns for a lot of health practitioners who say that these traditional birth attendants need to be trained to know what to do at the right time.
Now, we have to be very, very careful about the use of blanket terms. And traditional birth attendants is a blanket term, because a traditional birth attendant can be anybody, from the person who is taking it from his grandfather using cowrie shells to a retired midwife, a retired nurse who has retired from public service and gone back to her community and has become a traditional birth attendant. So be very careful about the use of blanket terms. What we are talking about are skilled birth attendants, and these skills only come about through training. WHO has run many, many programs which very many institutions in the country have used to bring traditional birth attendants and train them in infection prevention, control, recognition of danger signs. So if a traditional birth attendant is the community person that the community trusts, then we bring them on board. All we need is to be sure that the traditional birth attendant does not see a potential danger sign and then starts consulting the cowrie shells instead of directing the woman or doing what needs to be done. Because whether it's the traditional birth attendant is actually trained to do what needs to be done, which in many cases they can be and they are, or is trained to recognize that this is beyond me and refer to the next level of care. We do it even in the health system. There are people who go to the primary healthcare center, and even when they meet a physician there, the physician recognizes that, this is beyond the skill set and capacity of this facility and refers to the next level of care. So what a skilled birth attendant does is to be able to take care of all the things that can be prevented, all the first level care, recognize that this needs second level or third level care, and be able to refer appropriately. So let's be careful with the use of blanket terms. Traditional birth attendants are very, very valuable resources in any community. They are the ones that the people trust. And to be honest, when a woman is pregnant and going into labor, she wants to be with the people she trusts. So we bring them on board. Those that can be trained are trained and recognized and registered even. And those that are doing the wrong thing, well, we take notes and we gently try and direct the women to where they can get trusted healthcare that will assist them.
All right. Now, there is a projection by the UN which says in 2021, the number of deaths would be reduced to about 57.7% per 100 live births. I wonder if you see that happening with all of this you have mentioned and with the pandemic at hand.
Well, is that the global figure or is that the figure projected for Nigeria?
For
because
Nigeria.
It has to be decided. For Nigeria, well, it is attainable. I mean, the aim is to get to zero, isn't it?
Right.
It is certainly attainable. And what we are doing, the APHPN in collaboration with the community-based organizations and foundations such as the Wellbeing Foundation, is to look at what works. Look at the data, follow the science. What works, can it be scaled up? Does it need to be adapted to different communities? So what works in Lagos, will it work in the FCT? Will it work in Kwara, in Osun? Those are the things that we look at. And then we can now say that to everybody that, okay, this is working. How can it be adapted and adopted in the area where you are? If it can't be, what do we do? So that's the importance of it. And the thing is that so long as we're able to continue collecting the data, analyzing it and using it to project trends, then yes, there's no reason why we cannot get to 57.5 and beyond there to zero.
But certain persons, experts, think that our management of data in this part of the world is quite poor.
True. That is very true. It has been poor in the past. And that's because we have, there are for so many reasons that it has been poor in the past. We can't continue that way. Clearly, it is now obvious that we do need data. With the global pandemic, we've been able to, you can see what the NCDC is doing with data. It's absolutely incredible. And these are things that we can leverage on. Data worked for us with polio eradication. Data has worked. And what we need is an increased commitment to the use of computers, to the use of remote systems to be able to strengthen our data management. We've started federally. Of course, the private sector has shown the way. We've started in the public sector, and we just need to strengthen it and go on.
And in talking about scaling up, areas that we need to build on to ensure that we bring to the barest minimum issues that have to do with maternal and child care, what will that be moving forward on a general note?
On a general note, it will be, A, getting the local voices and bringing them to the global table. B, it will be empowering the midwives community, as not only as community communicators, but as community implementers. C, I envisage a situation where we begin to identify community champions amongst the women who have benefited from initiatives that have worked and bring them to participate in deciding and designing and developing strategies that work not only for their community, but the communities next to them, left and right. And then empowering the community midwives. We have to continue to build that cadre of healthcare workers. They are community health extension workers, they're community health officers, giving them access to that extra level of training that they will need constantly, because this training is not a one-size-fits, it's not a constant thing. There has to be continuous professional development with registration so that we can build a cadre of very skilled birth attendants to bring these figures down.
Another issue that is of concern to a majority of persons is the availability of primary health care in these communities because they believe that the state of the ones available now, it's not something to write home about. And at some point, the president talked about ensuring that it is improved upon, and he provides about 10,000 more. And this, the WHO says, has created the gap between the haves and the have-nots when it comes to access to quality care. I wonder, what do you make of this and how that can be addressed as well?
You are very, very right. The importance of primary health care in every community cannot be overemphasized, and it is true. The government's successive administrations have done incredible things in trying to improve access and availability of primary health care in every community. But the truth of the matter is we cannot continue to do the same thing and expect a different result. Now it is time for us to look at public-private partnership. The truth, the government has a lot to do. Its resources are oversubscribed in many, many areas. And of course, things like primary health care and primary education get the very short end of the stick. It is time for us to now look at strategic partnerships with private sectors, with private organizations, to get extra funding in that is dedicated to revitalizing the primary health care. And the fear of many people and the naysayers is that, oh, government is selling primary health care facilities to private organizations, and the private organizations are going to charge a whole lot of money. That is not true. We now have established systems where we can use health insurance. They've shown a fantastic strategy in Kwara State in the previous administration, the Shonga, what we call the Shonga project, that won so many global awards. It worked and is still working. And all we need to do is bring it up to scale, where you have the community leaders leading the administration of the funds that are accrued from the pooled resources and deploying them to the care and health care of the people. And of course, they can immediately be held to account. These things that are working elsewhere, it is time to take to scale. It's time for us to look seriously at credible public-private partnership that allows for accountability, allows for transparency, and allows for the local voices to become participants in the decision-making.
Absolutely. But one final thing that I would like for you to touch on, which is also a concern for some persons, is also the availability of quality health care practitioners. If we begin to look at, addressing issues of primary health care, availability of skilled labor workers, health practitioners that will be able to handle all of these issues. We see a lot of doctors leaving the shores of the country. There is said to be a dearth in the number of nurses. These are the issues that also needs to be addressed.
We have spoken about this time and time again, and it is true. Again, I'm saying it again. This is the culmination of decades of underfunding of the education and health sector. You cannot continue to churn out very highly skilled healthcare workers. If they were not highly skilled, if they were not well trained, they would not find jobs abroad. Their incompetencies would become immediately obvious, and they will come back to the country in disgrace. But the fact that they are not only finding jobs abroad, but they are being elevated to the highest position wherever they are, tells a lot about the quality of training that we are getting back here. And the truth of the matter is Nigeria is training the health workforce for the rest of the world. But when you train them, you can't provide them with jobs. If they get a job, you can't provide them with adequate remuneration. I mean, I'm pained when I had to stand in the corridor one day and literally give a newly qualified registrar permission to relocate to Canada because he told me that the money he was going to use to pay school fees for his children in the school that he attended as a child was more than the money it was going to take for him to transport his entire family to Canada, where a job was waiting for him with a house. How do you say, don't go? The man wants to provide quality education for his children in a school that he went to as a child, and his job as a doctor cannot pay for it. What do you say? So the government has to look seriously at, ASU didn't go on strike for nothing. They went on strike to collect the money for what they've already done. And then to say, look, let us have in place a credible university system with equipped laboratories, equipped libraries. We're not asking for too much.
Right.
But when you now put that and then the universities stay out of action for 1 year, do you think that people will not find their way to a better way of life? They will. So we have to look seriously at funding the education and the health sector. Those are the twin engines of national development. We can't get away from it.
All right, Vice Chairman, Second Vice Chairman, Association of Public Health Physicians of Nigeria, Lagos Chapter, Dr. Alero Roberts, thank you for your time on the program.
Thank you very much for having me.